Okay, so we have a case 31 2020, a 48-year-old man with lymphoma and abdominal pain, and which is presented by me, Houman Efranfar, and Florence and Victor. Okay, so medical history. In 2008, he was diagnosed with follicular lymphoma. Sorry. With follicular lymphoma, which was developed through lymphadenopathy in his axillary and inguinal region. We gave him rituximab for maintenance therapy, and other medications was rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. Also, 2013, he came back to the hospital, which recurrence of disease was there. Rituximab was continued. We also gave him other medications was there also, like cyclophosphamide, vincristine, and prednisone. We only stopped doxorubicin. In 2018, he was transferred to oncology care. There was a swelling in his right inguinal region, extensive FDG uptake, and chemotherapy was followed in his clinical remission. Medication was cisplatin, gemcitabine, and rituximab, and dexamethasone. As you can see, we're still continuing with rituximab. 4 months later, a stem cell transplantation was done. Acute deep vein thrombosis of the left leg, followed by treatment with therapeutic enoxaparin sodium. There was severe thrombocytopenia. Treatment discontinued after 1 week. 5 months later, there was a sign of lymphoma relapse. There was transfusion to diffuse large B cells and lymphoma after biopsy of enlarged axillary nodes. And the therapies was belantamab, chimeric antigen receptors, T cells, and pembrolizumab, and there was no response. Allogenic stem cell transplantation was considered. So 2.5 weeks prior to admission, patient was admitted to the hospital for severe pain in his epigastric and bilateral inguinal region. CT of the chest, abdomen, and pelvis revealed several clustered small pulmonary nodules. There was a progressive hepatosplenomegaly with normal appearing bile ducts, multifocal enlarged lymph nodes, and new small volume cysts. Medication resulted in elevation of pain, improvement in liver function, and discharge on the 5th day. And these are his lab results, as you can see. Medications were oral methadone and morphine sulfate, 5-day course of intravenous methylprednisolone. Several days before admission, patient was evaluated in oncology clinic of this hospital for recurrent severe pain, sharp pain, bilateral inguinal region, diffuse abdominal pain of upper quadrant, no longer responsive to oral analgesic agents. He had night sweats, decreased energy, poor appetite, nausea, and constipation. No fever, chills, headaches, vision changes, shortness of breath, cough, or dysuria. The medications that was considered, you can see all of them, such as aciclovir, triptorprime, and what? His family and social history. His family history: his parents, his mother had breast cancer, his father had coronary artery disease, hypertension, alcohol use disorder, and his children are healthy. His social history: his profession is information technology, lives with his wife and 2 adolescent daughters, smokes 1 cigarette daily, but quit 4 years ago before the admission. 1 beer every week, no use of illicit drugs.
Thank you, Houman. Um, I will start with the onset. So when the patient arrived at the oncology clinic, he came with a lean muscle mass and complication, which is cachexia, which can be a complication from patients with rheumatoid arthritis, and that will lead to pain, fatigue, depression caused by poor balance and even heart failure. And also we can see here he has dry mucous membranes, that's a thrush in the oropharynx, which can be a sign of candidiasis. And also he has soft abdomen, normal bowel sounds, which if it's tender in the right upper and lower quadrant region, we're looking at either hepatomegaly or splenomegaly. And he has painful lymphadenopathy in the cervical region and in the supraclavicular and inguinal regions. Next slide, please. Okay. Here also, we can see that from the complication of the cachexia, the patient was observed in severe pain and was also infused with IV morphine for the pain, and the saline solution, and also shaking, chills, and diaphoresis developed. That means we're looking at a sign of bacteremia from this indication of the shaking, chills, and diaphoresis. And also an indication that is an infection, the temperature is really high and the oxygen saturation is low, which is low blood oxygen and hypoxemia. Now, here, this can be also a case of aphasia because he has slow, nonsensical speech, which is the inability to comprehend or formulate language due to damages, which can be from stroke or other cardiovascular functions. And also, it can be seen in a quarter of patients who experience acute stroke always develop aphasia. Also, cefepime, meroperamide, and the metronidazole and acetaminophen are used for pain medication. They're used to treat moderate to severe pain medications. And the patient was put on fentanyl and for his pain control, and the patient mental status returned back to baseline. Next slide, please. So here we can see that in the physical exam, his vital signs, his temperature is a little bit normal, the pulse is above, the blood pressure is normal, the respiratory rate is a little bit above, the oxygen saturation is normal, the weight is a bit above and a bit normal, and the BMI is normal towards 18, which is still okay. Next slide, please. So here, wait, next slide, the previous slide, please. Previous slide. Next slide. Okay. The D-dimer levels are above the significant range, which is 1,166, and the amylase is also above the reference range. And we can see that we had to conduct CBC, a complete blood count, electrolyte and glucose levels to test of the renal and liver functions were also normal. And we also observed the chest radiograph. Next slide, please. So here, after the CT scan we did, we were able to find out that there were reviewed multiple new poorly circumscribed hypodense lesions throughout the liver and bilateral pleural effusions. So in the polycircumscribed, due to the development of these polycircumscribed hypodense lesions, we can be looking at metastasis. We can also be looking at some other complications that may present with this patient. Metastasis and pleural effusion can also develop, and also in the gradual reduction in the multifocal abdominal pelvic lymphadenopathy and stable splenomegaly with hypodense lesions. So whenever there was splenomegaly with hypodense lesions, we were able to observe that that this is an indication for disseminated fungal disease and microabscesses. And also the spleen is a rare site for metastasis, for metastatic disease also. So in the laboratory test, ammonia was 59, which is above, and lipase level of 260 was above, and amylase was also above the reference range. Next slide, please. So here we were able to see that after the MRI was conducted in the liver, that he had a confirmed presence of multiple ill-defined foci through the T2 region. And that's not specific for metastasis, but can also be identified as a benign based on the intensity of brightness in the T2 region. And also, whenever we see no dilation of the bile ducts, we can either be looking at cholangioitis, liver abscess, and secondary cirrhosis. Next slide, please. I'll hand over to my colleague Florence for this. Thank you.
Thank you, Victor. I'm going to continue from here. So we're looking at the CT and MRI scans of this patient. Looking at the first image, first and second image are the CT with contrast. And if you look at the arrows, it shows a polycircumscribed hypodense lesion throughout the liver. When you look at the diagram C and D, they also coronal contrast, CT with contrast, and they also showing a splenomegaly and also a lymphadenopathy. You can see that where they have the asterisk. Houman, can you make this a little bigger? Or
no, I can't.
Okay, it's okay. So looking at the D, E, and F images, these are axial MRI that's enhanced with gadolinium, and they also showing multiple lesions in the liver and spleen. Okay, next. So the diagnostic process. The chief complaint from all the signs and symptoms they saw, because this patient actually came in with a lot of symptoms, they finally decided that this is an aggressive recurrent disease, meaning that it might be his cancer, his follicular lymphoma that's coming back. So, and the possible causes that they can think of is from his immunotherapy, because like Victor listed, he was on a lot of cancer drugs that can cause myelosuppression of bone marrow. So they listed immunotherapy and immunologic overstimulation as one of the possible causes. There's also bacterial infection, and that could be from his fever, like Victor listed, the fever of 39.1 with the shaking, chills, and the diaphoresis. Tuberculosis. There's also lymphoma, and of course the immunosuppression from the drugs. Viral infections, it could be toxoplasmosis because of his immunosuppression too, and also fungal infections. Next, please. All right, so tentatively, they decided that this might be a fungal infection coming from a disseminated cryptococcal infection. And this is because of his subjective and objective signs coupled with the diagnostic results that they obtained. And also they had some blood cultures which grew cryptococcus. Uh, grew cryptococcus. They also did a CSF. It was initially negative, but eventually also grew cryptococcus. Next, please. So a diagnosis of cryptococcal infection was made. So the team decided on the management of this patient based on his neutropenic fever, which they called an oncologic emergency, and for the fact that they're not treating him with an antibiotic, that could be an increased risk of death. Also, the yeast in the blood culture and the new hepatosplenic hypodensities on repeated abdominal images also suggested the disseminated fungal infection. So they pretty much decided on empirical antifungal therapy, which was recommended because of the isolated yeast that's called cryptococcal neoformine. The medical treatment that they decided was with liposomal amphotericin B and flucloxetine. Cysteine. Next, please. So, like I was saying, the final diagnosis was a disseminated cryptococcus. And as you can see, the picture of this fungal. So it's a heavily encapsulated yeast, and it's found mostly in the soil, mostly from birds dropping, especially with pigeons. So it's acquired through inhalation with hematogenous dissemination. And this disease is it's usually with immunocompromised patients. In his case, it's from all the anti-drug that suppressed his immune system. It can also be seen in patients with AIDS too. Next, please. So the treatment therapy was with fungal medications. First was the liposomal amphotericin monotherapy, which was recommended for his CNS and disseminated infection. And also they try to consider his liver function and his pantothenium. They added flucytosine because it's usually added with the amphotericin B. Human, okay, thank you. It's usually recommended with amphotericin B. It works better with that. Next, please. So finally, unfortunately for this patient, he really didn't do well despite all the therapies that was instituted here. His repeat CT showed minimal response to therapy, and the team decided to pretty much be supportive. And this patient finally died on his 39th day of hospital stay. Next, please. And this is our where we got all the information from. Thank you.
All right, wonderful, wonderful. So, guys, questions. We'll start, and probably I will put my first question before because I see great job, guys, with posting questions. My first question is like this, and it goes to probably Florence. First of all, why do you think this case was posted or published in New England Journal of Medicine? What is interesting or unique or some kind of educational in this case required publication or allow publication of this case in this high-level, high-rank journal?
Well, when I read the journal, I think it has to do with uh, the side effects of cancer medication, and physicians sometimes try to look at other aspects instead of narrowing it down to side effect of medication, like we see in this case. The chemo medication reduces immune system, and that really finally was what killed him eventually from getting the cryptococcus deformans.
So what you're saying is this case just kind of like a warning for other physicians saying, well, do not miss uh,
Yes.
disseminated cryptococcosis in
Uh,
patients treated with chemotherapy, right?
Yes, to pretty much look for the just because the patient has cancer, there could be something else, going on with this patient, especially with the treatment that the patient has been receiving. In this case, the numerous anti-cancer medicine that he's been on.
Great. Wonderful. Well, I agree. I think it's one of the kind of important messages in this case. So what I'm looking through the article of this case, going through the article of this case, and I agree with you. So that's probably the message was, guys, well, don't miss the cryptococcus as a possible cause of what worsening of a condition patients who are on chemotherapy. My another question to you guys is, okay, what would you do different, or what doctor should do different in order to save this patient life? So, who would like to answer from your team? Let's say, what would you do if you kind of was aware about such
Um, uh,
complications?
so from looking at this, I will uh, first of all try to isolate the patient, because with this immune system being so low, he really should have been in neutropenic isolation uh, to start with, and uh, that might have saved his life.
So isolation. Do you think is there any kind of changes in the treatment protocol which you suggested for this patient?
Yes, maybe they could give him some medication to boost his immune system.
Mhm, mhm. So, what do you think? Was it a timely administration of anti-cryptococcal medication, antifungal therapy in this patient,
I'm
or it
sorry.
was delayed?
I'm sorry. What was the question?
Well, I'm asking, was the patient receiving antifungal medication on time, or it was delayed, actually, administration of antifungal medication in this case?
No, it wasn't delayed. They actually started empiric treatment initially, even before the culture came back. So when it was actually decided it was the cryptococcus, they changed their therapy to amphotericin B.
And so it means that the previous medication was not effective against cryptococcus?
E, no, the previous medication was for fungal, but not specific for cryptococcus. So
Mm-hmm.
cryptococcus is amphotericin B is used mainly. It's very sensitive to cryptococcus.
Got it. And what medication he received before starting amphotericin B?
I believe it was nystatin and something else here. Let me see. It was nystatin for his candidiasis, and uh, I think it's mycofungal. I can't remember the name. Sorry.
That's what I'm just kind of trying to find out, what kind of medication he received before they actually diagnosed cryptococcosis in this patient. So theoretically, we can actually, if I would be patient lawyer, I probably can sue the medical team and hospital for the mistreatment and misdiagnosis. What do you think? Will I win the case and get my $1 million?
No, I don't think you win the case.
Why?
Because looking at the journal, right from the first time the case was brought to the hospital, they did a lot of tests, they did a lot of CTs, and they followed up on all that. Whatever they found, they instituted some kind of treatment for it until they finally zeroed in on the fungal infection.
Did we do any biopsy to this patient to confirm what is inside of the lesions we found on their in the liver and spleen? So because what
no, there's no biopsy done on this patient.
No biopsy done was on this patient.
No.
Got it. So sounds like a good case actually for malpractice suit from my side. All right, so no, maybe I'm wrong, but let's say it's looked like patient died because proper treatment was administered late. So anti-cryptococcal medication was given too late when already infection was difficult to control because of a huge quantity of the pathogen in the body. So am I right in my statement or there's something wrong? What do you think, guys?
I mean, why would you say that?
The patient died, right? So this is what
right.
I'm saying. And based on what you said, the cause of the death was severe kind of disseminated cryptococcal infection, right, of the entire body. And it means that why cryptococcal infection kill? It could be either because medication was wrong diagnosis and late treatment. B, maybe not proper dose given of medication. C, maybe the medication was not working and this cryptococcus was resistant to the therapy. So what my question to you, what is in this case is why patient die? Is it because of late diagnosis or resistance to the antifungal therapy? So what is the reason?
I think it's resistant from the antibiotics.
Antifungal therapy. Not
I mean, I'm sorry, antifungal. Yeah, I think it's resistant. But then there's no way to actually see that because patient died eventually.
Well, we could actually analyze the cultures for the whether they resistant or not to the medication. So because you see, despite aggressive antifungal therapy, fungemia persisted, right?
Right.
And let's say after that, the patient not responded to therapy, and it looks like it's without any future fight. So patient just died. So you're suggesting that maybe one of the reasons for the patient death was lack of response to amphotericin, right?
Yes, that could be argued. Yes.
Okay, got it. All right, and one more question from this case, guys, for you. But you didn't show me lab data for the blood. Remember, it's hematology course. So I bring this on the screen. Does anybody from your team can tell me what's going on with what kind of anemia this patient has?
Yeah.
Based on those lab values. So, or maybe it's not anemia. So what you can tell me about the patient laboratory data?
So it's a macrocytic anemia because of the mean corpuscle volume numbers there.
So why do you think patient has macrocytic anemia instead of normocytic or microcytic anemia? So what is the reason for this macrocytic anemia in this case?
It could be from the anti-cancer drugs, immunosuppression,
Right. Well, anti-cancer medications, actually anti-neoplastic medications, frequently blocking actually kind of metabolism of B12, right? And let's say this leads to the classical signs of megaloblastic anemia. It's a well-known fact. So as well as many antineoplastic medication actually compete with folic acid or replacing folic acid. So folic acid deficiency develops in the patients. Again, in neoplasia causing also folic acid deficiency in general, and this patient has what? Lymphoma, right, guys?
Right.
So, by the way, what in case of lymphoma, what if you look at his lab values here, what is pointing to the diagnosis of lymphoma on this kind of laboratory data, what I'm presenting on the screen? What kind of feature, what kind of signs of lymphoma you see on this laboratory data?
Okay, so we see the smudge cells and we see the white counts.
Very good.
The platelets are all low.
Absolutely right. So this is definitely we have smudge cells. So classical kind of feature of lymphomas, particularly what kind of lymphomas usually associated with smudge cells? Who remember, guys?
CL.
CLL, absolutely right. Very good. Excellent. All right, guys. No, and last question. Let me take a look at the questions from the teams. I think there's a lot of pharmacology questions. I see. Yeah, it's everybody asking about amphotericin. So no, let's choose just one of the questions. Does amphotericin B cross blood-brain barrier, and is it appropriate for treatment of meningitis?
No, amphotericin B does not cross the blood-brain barrier, and it's not a good drug for meningitis.
All right, so thank you. I will record the answer. I cannot comment on this because, let's see, at this moment, I am not sure as well. So, and very good. Well, one more question probably I would like to ask you guys is, what is the mechanism of action fentanyl in pain management? Everybody ask pharmacology only.
Okay, fentanyl is an opioid agonist, and it acts primarily on the opioid receptors, and it's 100 times more potent than morphine, which results in an estimated conversion ratio of 1 to 100 to provide the equal degree to analgesia.
Wonderful. All right, guys. And I just don't getting why this patient was receiving actually fentanyl and other.
Because it was used to treat severe pain. Fentanyl can be used to treat severe pain and advanced cancer pain.
And why he developed severe pain? What's the reason for this pain?
From the indications that the presentation that he came with cachexia, which was a lean muscle mass, and at that lean muscle mass, there can be complications from rheumatoid for people with rheumatoid arthritis, which can lead to pain and fatigue and depression, or even heart failure.
I also think cancer always comes with pain, mostly from the bone sometimes.
Why cancer or mostly coming with pain? So what is the reason? So you think it's because of metastasis to bones?
Yes.
Does this patient had metastasis to the bones or not?
Well, there's
No,
no evidence for that.
Go on, guys, go on.
Okay. Victor, you want to answer this?
No, Florence, you can go, but I just wanted to add in something quick. But he also had liver metastasis too. That's all.
So he had liver metastasis. Liver metastasis potentially can cause pain, right, if liver size is increased. So he probably had also metastasis in the lymph nodes, in abdominal cavity, which may impinge on the nerves. And usually metastasis of any kind of cancer causing pain because they are either growing through or impinging, damaging kind of pressing on the various nerve endings. So causing with nagging chronic pain sensation. So in various parts of the body. So that's just remember kind of common situation. In this case also, I don't know, maybe he has already metastasis even into the spinal cord or maybe even the brain, but well, I'm not sure if I mentioned something about this here.
No.
No, okay, maybe he didn't have anything in the central nervous system. So it means in such cases, peripheral nerves were affected by metastatic nodules and maybe cryptococcal nodules, granulomas also probably cause the same things. So no, let's say we see here classical case of late diagnosis and the cause of the death is indeed, let's say if this patient get a more aggressive therapy earlier, then probably he would live longer. But in general, prognosis, of course, with leukemia, lymphoma is severe immunosuppression, infection, death. So this is kind of very common kind of scenario we see. No, this case is also not exclusion from this rule. All right, wonderful job, guys. Let me stop sharing and